these new formulations, kind of undo what BPO had as a bad name when they were more irritating and they weren't spreading well. Basically, what over-the-counter products, that are made poorly and cheaply have basically done to the legacy of BPO.
Welcome to the Learn Skin podcast with me, Dr. Raja.
And me, Dr. Hadar, where we discuss all things skin.
Join us as we delve into the art and science of skin health in today's episode.
Hey, Raja, can you say the thing I told you to tell them?
Of course. We are board-certified dermatologists. This podcast is meant for educational and informational purposes only and is not considered medical advice, nor does it serve as a substitute for professional care by a doctor or other qualified medical professional. All opinions shared do not express the views of Learn Health, Inc. Let's get to the good stuff.
Hey, Raja, how are you today?
Hey, I'm doing pretty well. I'm feeling like we need some new novel innovations that we need to talk about today. Not the same old, same old.
Well, you know what the definition of innovation is, right? Is actually taking something that is right there in front of you, but finding new application or improved applications. And when it comes to that, there's a few medications that we use routinely in practice every day, but maybe we can rethink our approach to them. What do you say about that?
Yeah, absolutely. In fact, it can change the entire character of them. I'm just as an engineer, I'll say, but we need an expert to help us think through all of this. And we've got just the guy. We've had him back over and over again, and it's because he's so much fun. Last time, I think he was in a car. Today, he's actually in front of a desk, and we've pinned him down, Dr. Neal Bhatia, and he's a board-certified dermatologist. He's down in San Diego, California, and he serves as the Director of Clinical Dermatology at Therapeutics Clinical Research. He's also Chief Medical Editor for Practical Dermatology. He has a lot of know-how, and also, I believe, you know how to tie a dhoti. Is that right?
Probably it's the only thing I'm an expert in. I'll definitely take that. I did have help with the dhoti and the whole kurta during the wedding, but that was back in 2013. So maybe I need an anniversary tie on. We'll see.
I got to say, I used to do a lot of performing, and every time you perform, sometimes people will give you like a gift of a kurta, which is like this really elegant kind of dress that you wear. It's an Indian thing. Oh my gosh, I have so many kurtas now. It's like way out of control, and I've got too many like insects like infesting all of them. I wish I had benzoyl peroxide for my clothes, but I'm sure that would have just bleached all of them. But anyway, let's get back to benzoyl peroxide. So Neal, what's new with benzoyl peroxide? It's been like tried and true for so many years, but there's just been new innovation that's come out that's really been actually pretty significant. So can you take us through BPO?
If you think of benzoyl peroxide, it's probably one of the oldest therapies we have. It's actually 2020 was the 60th anniversary of benzoyl peroxide in the world of dermatology. So it's interesting. And
wow.
Actually, if you remember back, benzoyl peroxide was used for acne back in 1960s. It was registered as a product. And, since then it's been, in many different formulations as washes and spot treatments. And over the years, even found its way in combinations like with clindamycin and adapalene. And now, we actually have a new version of benzoyl peroxide, which is called the microencapsulation version, which is in a silica gel that is easy to apply. It comes in a cream vehicle for both rosacea as a 5% and in combination with tretinoin, which is the first time those two have played in the sandbox together. It's really kind of interesting to see how BPO has evolved. It used to be, having this stigma with, it's going to stain clothes and it's going to sting and it's not going to work and blah, blah, blah. But, in fact, benzoyl peroxide has a lot of different mechanisms that really lend their way to both rosacea and acne, if you think about its potential mechanisms.
Yeah, I mean, when you're thinking about benzoyl peroxide, I guess now we have this whole microencapsulated versus unencapsulated. So what is the history of benzoyl peroxide and how did it? I mean, I know you said it didn't play well with tretinoin, for example, but I mean, how well did it play well on the skin itself? I mean, what were some of the issues that we'd seen before? And I know the approach to rosacea was probably, not one of, this is going to work, but maybe this is going to irritate. Do you have much experience trying the original benzoyl peroxide on inflamed skin like rosacea?
Yeah, I think, part of the benefits to rosacea come to some of the anti-inflammatory effects on especially some of the major cytokines involved, like interleukin-10 and some of interleukin-6 and some of those other combination potentials of mechanism. I mean, they're very broad and obviously not very strong, like something, more anti-inflammatory that we can think of, like steroids, for example. But the point of the exercise is, again, benzoyl peroxide has a lot of benefits that, again, with the irony of tretinoin, it can potentially oxidize tretinoin and, potentially neutralize it that way. But on its own, benzoyl peroxide helps, reduce bacterial resistance. It has its own bactericidal activity. When you're using antibiotics, the potential for augmentation with benzoyl peroxide really works itself well, especially in acne. Again, in rosacea, there's really not a bacterial component per se, like an analog to C. acnes. But the other part of the equation is, again, the anti-inflammatory benefits, have proven itself really be useful in terms of, direct application to the skin instead of as a wash. Whereas in acne, we use it as a wash for truncal acne as well as on the face, in the mornings. But again, as a spot treatment, it works also very well, to reduce comedones and again, enhance the bioavailability. And with the micronized version, that gets into the biosebaceous unit, that really helps, change the game a bit. So these new formulations, it kind of undo what BPO had as a bad name when they were more irritating and they weren't spreading well. And, basically what over-the-counter products, that are made poorly and cheaply have basically done to the legacy of BPO.
So perhaps we can expand a little bit about this encapsulation technique. Why was that selected, in your opinion, as a delivery mechanism for this? What are the general advantages of that from a drug delivery point of view, from safety point of view, and then why benzoyl peroxide kind of fits well for that?
Yeah, that's a good point of the evolution, because what's basically been done, and I'll just give you as a background, I was an investigator for Sol-Gel, served as one of their consultants as they were putting it through the tests, and now that they're with Galderma, I've been an investigative consultant for them. And basically the idea by microencapsulating it and, again, bringing the particle size down, the molecular weight down, it allows itself better penetration around the not only pilosebaceous unit in acne, but all through the dermis and the papillary dermis, especially when you're dealing with rosacea, where, again, the scene of the crime is the entire package of the top and middle of the skin. But by putting it into a silica monomer and encapsulating the tretinoin as well, you can basically put the two active ingredients into the same vehicle where they're emulsified together. And what happens is the monomers kind of work around, around the shell, if you will, and that makes an oil and water interface so that they're kept separate until the point of contact with the skin. And once that cream is basically hitting the skin, the pH of the vehicle changes, obviously. And from there, you get, the destruction of the silica shell and the release of the encapsulated benzoyl peroxide and the tretinoin at the same time. So even though they're in the same vehicle, they're not interacting each other. They're basically kept like in separate rooms of the house, if you will. And then once they hit the skin, they're allowed to basically penetrate into the skin and do their job. And I think that's a really easy way not only to enhance compliance, but enhance delivery and the benefits to each other, because they do have augmented anti-inflammatory activity, which is what we're seeing in acne. But again, with benzoyl peroxide, in that fashion alone, without tretinoin, we're seeing the benefits of rosacea because you're treating entire surface area, not spots. So I think the potential for what we're seeing with that encapsulation process can really bring not only enhanced compliance, but also enhanced delivery. And if you think about what benzoyl peroxide does, as an active ingredient in rosacea, we're not dealing with necessarily a bacteria, but benzoyl peroxide has, again, activity against free radicals. It has activity against some of the inflammatory components that, again, lead to oxidative stress. And all of those, again, really show itself as a potential agent for these patients who have been refractory to treatments, if you will.
That is an excellent overview of the technology. Thank you. You make it so clear. I think, Roger, what you left out of the introduction is that Neal is really a world-class lecturer. And so you have a great way of explaining things. I always love to listen to your explanation on this.
Especially when it comes to basic science stuff, you know what I mean? Because sometimes that can get a bit dry, but
Yeah.
not when.
Well, I mean, I would still bring a pillow and a blanket to some of my lectures if you.
Yeah. But don't bring the benzoyl peroxide unless it's encapsulated.
Unless it's encapsulated, exactly. It'll
Exactly.
go all over. It'll stain your sheets and with trouble. Which, by the way, again, this is where, again, the potential for mitigating some of those negatives comes into play, because even though in some cases they still may see like an orange discoloration or a little bit of bleaching from the molecule, a lot of those consequences were reduced in the trials. And we can get to that in a little bit, but that's actually one of the advantages to having a good vehicle is less stinging and burning and less potential for these kind of consequences. So I
Oh,
think that's
yeah.
a good outcome.
It's all about the vehicle. And thank you for taking us through this. So perhaps you can tell us now just kind of very basics. How do you tell your patients how to use this product when it comes to rosacea and acne, these products?
Yeah, the tricky part with rosacea is getting them over the stereotype of thinking, okay, well, this is just over the counter,
Yeah,
this is
exactly.
for acne, and then getting them past the issue of bleaching. Because again, with rosacea, you're mainly dealing with adults more than kids, obviously, and even more so, they're concerned about appearance. They don't want to stain their clothes. They don't want to look like they've got something gritty on. So, kind of the real pathway to getting them into benzoyl peroxide for rosacea is figuring out what they liked and didn't like from their other treatments. A lot of patients will come to us having used metronidazole gel, having used maybe ivermectin cream, or having taken doxycycline at different doses. Some may even have seen dermatologists where they used azelaic acid. So again, somebody's going to have some sort of consequence from before. And now with the new cream version, the trick is to talk to them about spreadability, about the ease of application at nighttime. But you still, we caution them about, okay, don't put it on like right away before you go to bed. Wash your face, put it on maybe an hour or so before you go to bed so things have a chance to absorb a little bit. And that way that might reduce some of the issues of staining of sheets and pillowcases. The other part too is, a lot of rosacea patients are worried about the sun and their photosensitivity issues. And fortunately, benzoyl peroxide's really not had a big history of being a photosensitizer. So, in that respect, we can, again, have them use it in the morning if they want to. But I try to have them use it at nighttime and again, an hour before they go to bed. I think that's an easier time for them to avoid any real concerns about, some of the staining issues or irritation issues. The other thing, again, is what we forget with rosacea is cleansing, moisturizing, and sunscreen. I think, those three components, no matter which therapy we use, are really essential to mitigating any kind of irritation or consequence. So again, make sure they wash their face, with a good cleanser, let it sit for a few minutes, and then rinse it. Make sure they put an even layer of the topical agent on, especially the benzoyl peroxide cream, which, again, will spread well, but they've got to cover all the areas affected. And then a moisturizer that's a little bit more pure and doesn't have sunscreen in it is more my preference because I like to have them use sunscreen separately. So I think just some of those extra little components of how to take care of the skin, even especially for guys who probably don't pay as much attention as females, but I think that's a little bit more important for them.
Neal, along those lines for benzoyl peroxide and the encapsulation, something about this encapsulation is so intriguing to me. It's slowing down how the benzoyl peroxide is being released, and its mechanism of action is still oxidative stress to, destroy whatever the bacteria or microbes that are present. Do you think it's being slowed down or controlled in some way we don't understand? Because, if we're not getting all these side effects, is it kind of like the Goldilocks principle where now we're finally delivering it in a just right way rather than just unloading the whole darn thing?
Yeah, you wonder, which is interesting. And it's a good thing you brought up oxidative stress because you figure the role of neutrophils in rosacea is pretty strong, especially how it affects MMPs and cathelicidins and all the other components under the hood of inflammation. And neutrophil, driven inflammation is very, very strong in rosacea. So that, again, the quenching of free radicals, the reduction of oxygen tension, and making sure that all the oxygen balances are equivalent is a big part of where benzoyl peroxide has its success. I think to the Goldilocks principle, which I agree with quite a bit, the value of a vehicle, like Hadar mentioned, is really significant in terms of ease of delivery, covering all surface area, making sure that, the active is not just released at, where the point of contact is on the skin with your fingers, but also, again, making sure that this is a marathon effect and not just a sprint. I mean, we do see some early results with benzoyl peroxide and rosacea, which is great. It's probably not the same as we would see with oral doxycycline, which has a different consequence, equation. But at the same time, you see some really good effects in comparison to, topical ivermectin and definitely topical metronidazole and topical azelaic acid. So, some of it also, again, goes back to the changes in baseline. I'm just looking at some study data while I'm talking here. Again, there were patients in the two studies that had almost, again, 20 or 17 to 20 papules and pustules reduced within a 12-week setting. in the studies, but there were significant improvement results documented at week 2 and at week 4. So again, the sprint effect was very good from what they studied in the 5% cream.
One of the things that excites me about benzoyl peroxide, maybe you can talk about this, is the speed at which it was working for rosacea, like you're saying. And I wonder if that means that, even coming from an integrative perspective, does it mean that you can get the rosacea under control much faster, and then you can focus on, how you're going to say, long-term management, if you're going to work on gut microbiome, or if you're going to do other topicals or other sort of dietary changes. But it's really nice when a medication works quickly, because then the patient sees that, hey, this is working, and then they get motivated to other things. I mean, can you comment on the speed compared to other ones?
Especially in rosacea, where patients want to get rid of the redness as fast as they can. They want to feel the resolution of papules and pustules as fast as they can. Having measures of absolute change at week 2 compared to when they start is critical, because part of the flaw, I think, of dermatologists is seeing rosacea patients back in the clinic too quickly. You want to let the medications do their job. And truthfully, in Florida and California, as we all three know, we got $75 copays to see a dermatologist and high deductibles. So I would rather patients spend the money and the time letting the medication do their job, and have them come back to me when I know that the endpoints are going to be better. And I know at week 2, we could give them a call and say, hey, how are things going? Because we also know if you superimpose the benzoyl peroxide data from the trials over the ivermectin data, over the azelaic acid data, the benzoyl peroxide data is superior, especially in week 2 and week 4. With that, again, by week 8, then you want to check in on your patients and say, all right, how are things going? And truth be told, I mean, a lot of us, treat rosacea with multiple modalities. Like we may.
Yeah, exactly. I was just going to ask you that.
Yeah. I mean,
you nailed it. It's like, we're not doing anything monotherapy.
We're not doing anything monotherapy. So we can take the study data and say, okay, duplicate that with, oral doxycycline and 40 milligrams, and give me the 5% benzoyl peroxide, and let's let it rip. That's what we want, right? And I'm a big believer, as we all are, of treating inside out and outside in when you can, and safely do it, because you're optimizing your approach to all of the inflammatory cascade. So I think that's a really easy way to get patients going. And then by week 12, you can probably see them back and say, okay, where are we at here? What do you want to keep going with? And what's going to maintain you? Because, again, we go back to the marathon, and I think we can just find a way to get them onto something that they want to stick with, and they'll go from there.
Yeah, one thing with clinical studies I think is very interesting is, you get to see the efficacy, but what you don't always hear about is like tapering regimens. And I think that's left up into the I would say, physicians or practitioners' hands. Because you mentioned maintenance, which I think was a great segue. I mean, how do you approach maintenance once they've hit like their goal? Do you start applying it less often? I know this is off the FDA label, but I want to ask you as a physician, do you start bringing it down to 3 times a week, or do you do like every other day? I mean, what is your approach? Because a lot of my patients ask me this question. It's like, how now what do I do?
We don't have to worry about labeling this. Nobody's going to come after us.
Absolutely, no. That's the beauty of the Learn Skin podcast.
Yeah, well, exactly. Well, but podcasts, they can't even see us, so you can't even find me. But so the key to the equation, I think rotation is great. I'm always a fan of saying, look, we got you to clearance at this point. Start doing every other day if you want. Treat it like a stereo. Turn it up and turn it down. Just don't turn it off. And if you maintain yourself with every other day, keep going, and let's see what happens. If we're on multiple modalities, we can do one thing one day and one thing the next day. And again, keep the maintenance going, keep the music flowing, if you will. And then if things start to flare up again, you turn it back up again and go back to every day. And I think that's an easier way of, not in a bad way, to keep people out of the office, but I'd rather keep rosacea patients out of the office and let them do their work rather than having them come back and tell me things aren't better. Because then after a while, I start to lose things in my toolbox, and we're throwing multiple things at the kitchen sink, if you will. And we don't want too many things touching their skin and knowing how sensitive it is.
Absolutely. And I love that concept of turn it up, turn it down, but don't turn it off. I feel like that's so true for many of these conditions that we treat in clinic every day. I wanted to ask you about rosacea, because the data, I think, really relates to the papular pustular type of rosacea. What about the erythema and telangiectasias that we see in rosacea? Does the new benzoyl peroxide formulation have any effect on that?
So that's interesting because if you take the structural component of rosacea, and especially the telangiectasia, that's the most difficult thing to resolve with any topical therapy. The angiogenesis component that goes along with, again, the cathelicidins and the recruitment and the vasomotor parts of rosacea probably will be impacted over time. And you'll see less erythema as you see less inflammation. But to see less telangiectasia, I think, is a bit of watch and wait. I think that, again, some skin types are going to be more prone to those vessels just being there versus others. Again, as the angiogenesis components are reduced and, some of the newer components of rosacea, the vanilloid receptors and the toll-like receptors and the others that are promoting more vascular recruitment, as they slow down, and as we've been talking about with the oxygen tension, as that slows down, you'll see less and less of the free vasculature starting to develop. So there may be some component to that. Again, that's a little too scientific for our audience to really chew their teeth on. But I think the idea is that that component will be improved. But, the other point, Hadar, that I think we talk about sometimes is the texture of skin. And, benzoyl peroxide, by reducing the free radicals in the skin will actually help, restore some of the dermal stroma, as well as, again, help to promote a little bit better fibrosis to the dermis. And that might help the texture for most of those patients. The papules and pustules, as the inflammatory part should resolve, as the inflammation resolves. But I think those other components that you mentioned, the telangiectasia and some of the other ruddy changes to the skin, should improve over time. I think rhinophyma might be a little bit of a stretch, but I think, every little bit helps. And, that's where, again, the tretinoin component of that combo product, even though it's indicated for acne, for someone with really heavy textural change, I might consider using some of that instead.
This encapsulation technology, obviously benzoyl peroxide's in there. We have tretinoin that's now been incorporated in there. Can you think of any other molecules that you could imagine that could get encapsulated in here? I mean, do you think, like, for example, encapsulating azelaic acid into this kind of technology, would it make it less irritative? I mean, all those things that cause irritation, like, can you make them less irritative by doing that?
Yeah. So it's funny because irritation and function tend to go hand in hand, especially with desquamation and acne. And a lot of times we'll tell our patients that even though it's irritating and drying, some of the skin that you're seeing peeling off is actually the bad skin. I mean, that's a little bit of a stretch sometimes, but if, talking points like that actually help them to kind of ride it out. And it goes back to what I was saying before too. Some of it is how we moisturize and cleanse to reduce that irritation. But azelaic acid, we see azelaic acid compounded in many different packages, in a lot of nutraceutical as well as some other cosmeceuticals. And it's a pretty stable actor in those respects. I don't know how a higher percentage, like we see pharmaceutical grade 15% or 20% azelaic acid would do in this process. Now, again, the way the encapsulation, or microencapsulation works, one would think that we could preserve almost anything and keep it separate in that silicate model where the oil and water emulsion is keeping the actives separate. I think the question becomes how well will it do over time, and will that combination be effective? But I think, we could think about azelaic acid, you could think about minocycline, you could think about some of the other agents that we haven't had a chance to put into partnership. Obviously, like I said before, we've seen clindamycin and adapalene as benzoyl peroxide's two most common friends in combo. But, could we package some of these other agents that would be great for minocycline? Yeah, absolutely. For rosacea, I think absolutely. I think the sky's the limit if you look at it that way. I think the bigger thing, and Raji, you brought this up before, I mean, if we go back to the poorly made BPOs and the bad vehicles, I mean, again, the efficacy may be there, but the shift of the microbiome and the potential for absorption and, of course, irritation, they all really can change the game a little bit. So, having the right partners and the right, components that are in the actives, I think makes a big difference.
Yeah, I mean, all great points here. I love the point that you're making to just bring us back to this conversation of the original BPO. The OG may not be so great now, comparatively speaking. But I think the takeaway here is that this encapsulation process has really shifted its properties. And so, all these things around, I know there's controversy around, does a BPO lead to enhanced, collagen breakdown, or does BPO lead to more irritation? We just talked about a little bit about that. Or does BPO lead to more bleaching? I mean, it seems like this encapsulation process really turns all that down. And so then it leads me to my next question. I have had a few pharmacists that'll contact me and say, can I please substitute the generic? And I think it's really important to point out that this is a situation where you can't substitute a generic because that's literally what we don't want. And we want the encapsulated form.
Oh, yeah. I mean, that's completely wrought with peril because, again, it totally defeats the purpose of using benzoyl peroxide in a condition like rosacea where, again, you're already dealing with hypersensitive skin. You're already dealing with compromised barrier and, the potential for not only irritation, but poor efficacy because of the lack of encapsulation and delivery. And again, like you brought up before about the microbiome and the shift and the change of what that's doing to all the components of the barrier, I think that's really going to lead to more problems than solutions.
Well, Neal, this was the most I've ever talked about benzoyl peroxide, but I wouldn't have wanted to do it with anyone else besides you two.
Absolutely.
And I really appreciate you coming on here and taking us through this new innovation. It's basically taking an old dog and not just teaching them new tricks, but you actually make them act differently. So what do you know? All those old adages just go to the side. And you can teach an old man how to tie a new dhoti, as we say.
Oh, exactly. Well, listen, anyone who wants to watch a good Indian movie and see how clothes should fit would do well. If the Academy will be in San Diego in 2024, we should all wear dhotis and.
I'll do it. I'll do it. I'll print my practice on there and I'll come and do it. It'll say like I don't know, Zen Dermatology or whatever the heck, and we'll print all of our practices on there.
I'll go shopping right now. I'll start shopping.
Yeah. University of Miami for you, Hadar. Totally. University of Miami dhotis.
But if they see us being the ones who are driving the rickshaw, then I think we're in trouble.
Well, you know what they'll do? You know what? They can put branding on the dhoti because everyone would be looking at us anyway, so might as well.
That's true. Heck? Put the learned skin dhoti on and have at it.
Put the learned skin dhoti on.
Yep. Exactly.
All right, Neal, we love having you on. We'll do it again soon.
Oh, it's an honor, you guys.
And we'll see you at the Integrative Dermatology Symposium in Tucson coming right up.
Can't wait. That'll be fun. Well, thanks you guys. Thanks for having me. It's always a pleasure.
Thank you. Hey, Raja, do you know where the integrative medicine movement started?
According to Google, since Google knows everything, Dr. Andrew Weil founded the Center for Integrative Medicine at the University of Arizona in Tucson back in 1994. Why do you ask?
Well, you know how we always try to get to the root cause? I think we need to go big for the fifth annual Integrative Dermatology Symposium. How about we do this? Let's meet at the Los Ventana Canyon Resort in Tucson, Arizona. Or you can join virtually from September 30th to October 2nd and hear from the world-renowned experts like Andrew Weil.
Exciting. And our theme is connecting mind, body, and spirit to take a more holistic approach to our patient care. What do you say?
Absolutely. I mean, where else can you get the latest on diet and dermatology, hypnosis, botanicals, common diseases, aesthetics, and other unique topics in dermatology with practical takeaways to start using in clinic right away?
So true. And let's not forget, we've got the new track for estheticians too. I think I'm going to need to call in a sick day or two before the symposium so I can enjoy the waterfall and trails on the resort, stargaze, play a round or two of golf or tennis, relax at the spa, and catch up with colleagues at the evening receptions.
Yes, that place is spectacular. Use our discount code POD25 at checkout for 25% off.